Good morning. Today we will be discussing the topic chronic myeloid leukemia. Chronic myeloid leukemia will be discussed under the following subheadings: introduction, cytogenetics, clinical features, lab findings, and treatment. Chronic myeloid leukemia is a myeloproliferative neoplasm arising from neoplastic transformation of pluripotent stem cells with the predominance of overproduction of granulocytic series. So, as the name indicates, it involves or it is the neoplasm of the myeloid series. The myeloid series include the granulocytic series, erythroid series, and megakaryocytic series. But in chronic myeloid leukemia, the granulocytic series is affected more, or it involves the granulocytic series, which includes neutrophils, basophils, and eosinophils. This is a quite common condition and comprises about 20% of all leukemias. It usually affects adults, that is, people belonging to third and fourth decades of life. This condition is rare in children, and there is a juvenile variant called the juvenile CML, which is seen in children. It affects both sexes equally. According to WHO classification, the myeloproliferative neoplasm includes the chronic myeloid leukemia, BCR-ABL1 positive, chronic neutrophilic leukemia, polycythemia vera, primary myelofibrosis, essential thrombocythemia, chronic eosinophilic leukemia not otherwise specified, myeloproliferative neoplasm unclassifiable. Chronic myeloid leukemia shows or is characterized by a peculiar cytogenetic alteration. That is, it possesses balanced reciprocal translocation of chromosome 9 and 22, forming Philadelphia chromosome. This translocation results in the fusion of BCR gene on chromosome 22 with ABL gene located on chromosome 9, resulting in BCR-ABL1 fusion gene. The BCR-ABL1 fusion gene product bring about following functional changes. ABL protein is activated to function as tyrosine kinase enzyme that in turn activate other tyrosine or other kinases that inhibit apoptosis. Ability of ABL to act as DNA binding protein is altered, and the binding of ABL to act in microfilament of cytoskeleton is increased. All these result in uninhibited excessive proliferation of the granulocytic series in the bone marrow, resulting in a neoplastic condition. Apart from BCR-ABL fusion, other genetical alterations are also involved in chronic myeloid leukemia, which helps the disease to enter a blastic phase. What is a blastic phase? We will learn later. And these alteration or genetic alteration include alteration of tumor suppressor genes P53 and RB gene, alteration in oncogenes like RAS oncogene and MYC oncogene, and release of cytokine interleukin 1 beta, and functional inactivation of tumor suppressor protein phosphatase A2. Now coming to the clinical features with which a patient with a CML, the clinical features that a CML patient will manifest. These include anemia, so that the patient will be presenting with a weakness, pallor, dyspnea, and tachycardia. Hypermetabolism, due to which the patient will be suffering from weight loss, lassitude, anorexia, and night sweats. Then there will be splenomegaly, which results from extramedullary hematopoiesis as well as the infiltration of spleen by leukemic cells. And the spleen will be often massive. The splenomegaly is often massive with a splenic infarction may occur. Bleeding tendencies will be seen, especially in the later stages due to thrombocytopenia or decrease in platelet count. The patient will be presenting with the easy bruising, epistaxis, menorrhagia, and hemorrhage. Other clinical manifestations include gout, visual disturbances, neurological manifestations, and priapism. Also, the patient will be presenting with a hepatomegaly, lymphadenopathy, and sternal tenderness, especially due to infiltration of these organs by leukemic cells as well as extramedullary hematopoiesis. In juvenile CML, the children will be presenting with the lymph node enlargement, infections, hemorrhagic manifestations, and facial rash. Now, coming to the lab findings in chronic myeloid leukemia. When we take the RBC or in the peripheral blood, we can see normocytic normochromic anemia with occasional normoblast. The platelet count will be normal or raised in the early stages, that is in the chronic phase of the CML. Usually the platelet count will be normal or the patient will show mild thrombocytosis. Now coming to the WBC, there will be marked leukocytosis. That is, the WBC count will be about 2 lakh per microliter or even more. The predominant cells will be neutrophils with a marked shift to left, showing predominantly mature neutrophils and its immediate precursors, especially myelocytes, metamyelocytes, and band forms. Since CML involves not only neutrophils but also the entire granulocytic series, there will be associated increase in eosinophils and basophils, resulting in eosinophilia and basophilia. So, in CML, neutrophils with a neutrophilia with a shift to left is not enough. There should be eosinophilia and associated basophilia also. And chronic myeloid leukemia can be divided into 3 phases: chronic phase, accelerated, and blastic phase, especially based on the percentage of blast which is seen in the bone marrow or peripheral blood. First is chronic phase or the early phase. In this, the blast percentage is less than 10%. Usually in chronic phase, the blast percentage is about 2 to 3%. Anyway, it will be less than 10%. And there will be excessive proliferation of intermediate grade neutrophil precursors like myelocyte and metamyelocyte, and mature segmented neutrophils can be seen. Apart from this, there will be basophilia with a basophil count of about 10%. Then there will be eosinophilia also. The next stage is accelerated phase, where the blast counts start increasing in blood or bone marrow. That is, it will be between 10 to 20% or 10 to 90%. There will be progressive leukocytosis, and bone marrow basophils will be 20% or more. Also, there will be fall in platelet count. So, the early stages of chronic phase, there will be mild thrombocytosis, but when the patient enters into the accelerated phase, the platelet count start falling, and it will be usually less than 1 lakh per microliter in an accelerated phase. Next stage is the blastic phase or the blast crisis, in which the number of blast in the peripheral blood or bone marrow will be more than 20%, like that in an acute leukemia. So here the CML resembles an acute leukemia with more than 20% of blast in the blood or bone marrow, and there will be severe thrombocytopenia and anemia will be seen in association with the increase in blast. This is the peripheral blood finding or peripheral blood picture in chronic myeloid leukemia. Here you can see the majority of cells are neutrophils and its immediate precursors. You can see mature segmented neutrophils here, as well as its immediate precursors like metamyelocyte and myelocyte. Also, you can see basophil and eosinophil, as well as a normoblast can be seen in this picture. Now, coming to the bone marrow examination. The striking feature which is seen in bone marrow examination is its increased cellularity. So, first of all, the bone marrow will be hypercellular with a total or partial replacement of fat spaces by the myeloid cells. So, we know that the chronic myeloid leukemia occurs in adults, and in adults, most of the or a major part of the bone marrow will be composed of fat spaces. But in chronic myeloid leukemia or any myeloproliferative neoplasm, we can see that the marrow spaces will be decreased and the hematopoietic elements in the marrow will be increased, resulting in a hypercellular marrow. When we come into, when we see the myeloid series, the myeloid cells predominate the marrow cellularity with increase in myeloid to erythroid ratio than normal. Coming to the erythropoiesis will be normoblastic with a reduction in erythropoietic cells. And when you look at the megakaryocytes, the megakaryocytes are conspicuous but are usually smaller in size than normal. This is the normal marrow cellularity in a normal individual, and this is the marrow cellularity which is seen in chronic myeloid leukemia. So here in this marrow, you can see that there are many fat spaces. This is a marrow of a normal adult. So there you can see this, all these white spaces are fat spaces. But when you see this marrow, you can see that there are very little fat spaces here, and most of the marrow is replaced by hematopoietic cells, or the marrow cellularity is increased. So this is the bone marrow aspirate picture of a normal individual, normal healthy individual and a CML patient. Here you can see that the marrow of a normal individual is composed of myeloid series which predominate, but you can also see erythroid series. Many erythroid precursors can also be seen here, and also there are large megakaryocytes. But here in a marrow of a CML patient, you can see most of the cells are cells belong to the myeloid series. So there are very little or very few erythroid precursors are seen in this field, and you can see the megakaryocyte. Megakaryocyte is smaller compared to a normal megakaryocyte. Now, to confirm the patient is having chronic myeloid leukemia than any other myeloproliferative neoplasm, a cytogenetic study is very mandatory. So in cytogenetics, you can see this reciprocal translocation involving chromosome 22 and chromosome 9, resulting in BCR-ABL fusion gene and formation of Philadelphia chromosome. Also, you can look for the NAP score or neutrophil alkaline phosphatase score, which will be reduced in CML. The NAP score will help to distinguish this chronic myeloid leukemia from leukemoid reactions. Leukemoid reaction is a non-neoplastic condition or a reactive condition which closely resemble the chronic myeloid leukemia, because in leukemia reaction also there will be the WBC count will be very much elevated with the predominantly neutrophils with a shift to left. But in leukemia reaction, the NAB score will be elevated, while in chronic myeloid leukemia, the NAB score will be reduced. Other investigations which are not specific include elevated serum B12 and vitamin B12 binding capacity and elevated serum uric acid level. So the major lab findings which helps in the diagnosis of chronic myeloid leukemia includes peripheral blood examination, bone marrow examination, cytogenetic study. Now coming to the treatment. The treatment involve imatinib oral therapy, allogenic bone marrow and stem cell transplantation, interferon gamma, chemotherapy using busulfan, cyclophosphamide, and hydroxyurea. Others include splenic irradiation, splenectomy, and leukapheresis. As we conclude, the points to be kept in mind are: chronic myeloid leukemia is a myeloproliferative neoplasm, which is the neoplastic transformation of pluripotent stem cells with the predominance of overproduction of the granulocytic series. And the specific cytogenetic alteration which is seen in chronic myeloid leukemia is a balanced reciprocal translocation of chromosome 9 and 22, forming Philadelphia chromosome containing BCR ABL fusion gene. And the diagnosis of CML depends on mainly the peripheral blood findings, bone marrow findings, and cytogenetic findings. The peripheral blood show marked leukocytosis with the neutrophils showing marker shift to left. In addition to this, there will be basophilia and eosinophilia. And bone marrow will show hypercellularity with the predominance of myeloid precursors and increase in M ratio. Again, CML can be divided into 3 phases, that is chronic, accelerated, and blastic phase, depending on the percentage of blast in blood or bone marrow. The treatment modality include imatinib therapy, interferon gamma, interferon alpha, chemotherapy, and stem cell transplantation. Thank you.